Good morning, everyone. For our physical examination module, our first topic is going to be about the skin, hair, and nails. We're going to learn about physical examination, of course, but along the way, we're also going to review the anatomy and also discuss some topics about health promotion. So this is going to be the outline for our discussion. We're going to learn about how to properly take the history for common symptoms. Also, we're going to learn about inspection and palpation of three special skin cancers, or the most common skin cancers, namely basal cell carcinoma, squamous cell carcinoma, as well as melanoma. There are ways and techniques to assess for changes in hair and nails as well. Along the way, we need to learn about the accurate terminology for describing such findings. So there are some terms that are specifically used only in dermatology. Of course, we need to have a visual familiarity with some of these skin conditions. And lastly, for the clinical aspects, we need to have updated information for skin cancer prevention and screening. The skin is the body's protector. It's a vital organ that maintains the body's homeostasis. In a way, you can think of the skin as part of the body's immune system because it separates the self from the non-self. It retains fluids, protects tissues from external threats. It also regulates body temperature. So for example, if it's warm, your vessels near the skin is going to vasodilate to help remove the excess heat. If it's cold, it's going to be the opposite. You're going to vasoconstrict. It also synthesizes vitamin D because you need UV rays, no, to synthesize the proper form of vitamin D. It also has appendages. The appendages are hair, nails, and the different sweat glands. Sebaceous glands are also part of the skin. What's the largest organ in the body? Remember, it's actually the skin. So it's also the heaviest. It accounts for about 16% of our body weight. And there are three basic layers of the skin: the epidermis, dermis, and subcutaneous tissue. The epidermis could further be subdivided into 5 layers: basale, spinosum, granulosum, lucidum, and corneum. Lucidum is only found in certain areas of the body. So the epidermis is the most superficial and is a thin vascular layer. Actually, the cells are only alive in the basale layer. It's the stem cell niche for this particular layer of the skin. So as we move higher, the cells from becoming more cuboidal becomes flattened and more squamous and keratinized, and they're all already dead by then. Also, there's an inner cellular layer here where melanin and keratin are formed. So depending on your skin color, you can have a lot of melanin. True melanin is dark hue melanin, or a lighter form of melanin. On the other hand, below the epidermis is what we call the dermis. So, when you're desquamated, when you have burns, for example, you can see a pale layer. That's actually the dermis. The dermis is a dense layer of collagen and elastic fibers. Located in the dermis are the glands, hair follicles, as well as nerve terminals. If you would remember your neurology, there are many different nerve terminals for deep pressure, for pain, for temperature. There. Also, because the dermis, the one that's alive, is the one that provides nutrition to the epidermis. And lastly, the deepest layer is actually the subcutaneous tissue, and it merges with the dermis. There's no clear demarcation, unlike between the dermis and the epidermis layer. The subcutaneous tissue consists primarily of adipose or fat tissue, unlike the dermis, which is composed primarily of connective tissue. So what's going to determine the color of your skin? There are various factors. Specifically, we're going to look at 4: melanin, hemoglobin, carotene, and bilirubin. Okay. So melanin has 2 types. There's eumelanin and pheomelanin. Eu means true, right? So eumelanin is browner and darker in color. So it's genetically determined, right? So depending on your race, depending on your heritage. Also, it's going to be increased by sun exposure. So there are some types of skin, some Fitzpatrick types, that's going to determine whether you tan or you burn. Most Filipinos, we tan, right? That's why after we go to the beach, we look darker. Or if we don't wear sunscreen, we're going to look darker. Another determinant of skin color is hemoglobin. So the oxygenated form found in the arteries is oxyhemoglobin, which is a brighter red pigment. In contrast, once it passes through the capillary bed, it's going to look like darker because it's going to be deoxyhemoglobin. Another factor is carotene. Carotene is a yellowish pigment. It's a derivative of cholesterol and it's also related to vitamin A. It's a yellowish pigment, and because it's a fat-soluble vitamin, it comes from a fat-soluble vitamin, it's going to be stored in the subcutaneous fat. Specifically, you could see it best in heavily keratinized areas like the palms and the soles. So there's a condition called carotenemia. So people who eat excess of carotene-rich food, such as carrots, obviously, are going to be slightly yellowish. So you have to differentiate that from a pathological yellowing called jaundice. Okay? So carotenemia, if you stop taking carotene-rich foods, is going to normalize. But jaundice is a more worrying problem. Jaundice is caused by the presence of bilirubin. Bilirubin is a yellow-brown pigment resulting from the breakdown of heme in the red blood cells. Why is it important to learn about skin color? Because it's an important diagnostic clue. Specifically, we're looking at pallor, cyanosis, and jaundice. So first for pallor, in Tagalog, pamumutla. So where are you going to see pallor? Here in the palms, no? Pallor is actually a pretty late sign of anemia. It only manifests at around less than 7 grams per deciliter of hemoglobin. And the normal hemoglobin is around 10 to 11, right? So it's already pretty late. Next would be cyanosis. Cyanosis could be divided into two types: central cyanosis and peripheral or acrocyanosis. Peripheral cyanosis could be observed at the extremities as well as the circumoral or perioral area. Peripheral cyanosis is less worrying. Why? Because acrocyanosis is caused by decreased blood flow to the peripheries. But central cyanosis means there's a deeper underlying problem, either cardiac or pulmonary in origin. So central cyanosis could be seen in the mucous membranes. So for example, if you look at the lips, if it's turning blue already, that's more worrisome. And lastly, we have jaundice. If we remember the breakdown of heme gets converted by heme oxygenase to biliverdin. And from the name, verdin, you could see that it's actually a green color. From there, biliverdin gets converted to bilirubin, which is more of a yellowish color. So for whatever reason, if you have a problem in removing this bilirubin in your intestines or excreting it in your intestines, then you're going to have a yellowish color of your skin if it accumulates. We have 3 skin appendages: hair, nails, and glands. So for adults, iba syempre kapag pediatric, especially pag newborn, ano? For adults, we just have 2 types of hair: villus hair and terminal hair. Villus hair, yung most hair sa ating katawan. Short, fine, and inconspicuous hair. Terminal hair, yung hair here sa ulo, no? Coarser, thicker, and pigmented. Sama mo dyan syempre yung beard, etc. Okay? Nails protect the distal ends of our fingers and toes. So, in our nail, meron kang proximal nail fold, lateral nail fold, and yung pinakakuko is the nail plate. So, the normal angle between the nail fold and the plate should be less than 180. So, hindi naman siya dapat napa-flat or nagka-club na yung kuko. So, the nail plate is attached to a vascular nail bed, giving it a pink color. So, nasabi ko nga, di ba? With acrocyanosis, the nail plate may have a bluish tinge. Now, for the glands, we have 3 types of glands here: sebaceous, acrine, and apocrine. Sebaceous glands produce a fatty substance called sebum, secreted through the hair follicles. It is absent on the palms and soles. That's why our palms and soles are hairless. While the eccrine glands are more widely distributed. So this is like the watery sweat that we have. It helps control body temperature. It helps the body cool down through evaporation. And lastly, for the apocrine sweat glands, this one is responsible for our body odor. These glands are located in the axillary and genital regions. So when the bacteria decompose the secretions produced by apocrine glands, it causes body odor. So what are the things that we should ask for in the history taking portion? If the main concern is skin, hair, or nails. So for skin, we could ask for these things. If there's any recent growth recently, something like a tumor, or maybe a mole that has changed in size, symmetry, and appearance recently, and if there's any new growth, we could ask about any personal or family history of skin cancer. It could be as simple as asking if whether we have any relatives that have undergone operation recently in order to remove some new growth. Of course, we should also ask for the use of sunscreen because UV exposure by the formation of thymidine dimers actually predisposed to the to many types of skin cancer. Okay, for each type of new growth, we could document the type, location, as well as the date of any past skin cancers. For rashes, it's very important to ask about itching because itching is associated with an allergic reaction. Of course, you could ask also about other aspects of having an allergic reaction, such as any watery eyes and itchy eyes. You could also ask for its timing relative to allergies or any other treatment use, especially if they're trying out a new skincare routine or regimen. Okay? Generalized itching without a rash can indicate systemic diseases, especially among adults who have long-standing chronic illnesses, for example, diabetes or chronic kidney disease. Lastly, you should ask about hair loss or nail changes. For hair loss, you should ask whether there is any thinning or shedding in the past few weeks or days. And if the hair is shedding, you should ask whether it comes off from the roots or if it comes off due to breakage. You could also ask about any hair care as well as nail care practices. Okay, so some nail findings such as onychomycosis are very obvious. As part of health promotion, we should of course screen for skin cancer. It is the most common cancer in the US, mostly because they are fair-skinned, unlike us, most of us Filipinos. Skin cancers are caused by both genetic and environmental factors. So it's a mixture of genetic predisposition as well as UV exposure that causes the formation, once again, of thymidine dimers. So what are the three most common types of cancer? Basal cell carcinoma, squamous cell carcinoma, and melanoma. So among these three, the most common one is basal cell carcinoma. The second most common one is squamous cell carcinoma. And the least common, but most important because it's most lethal, is a melanoma. It causes over 70% of skin cancer deaths. But in contrast, basal cell carcinoma and squamous cell carcinoma are less deadly. So the National Cancer Institute of the United States have developed a risk factor assessment tool for melanoma. It includes screening for the following risk factors. So these are the risk factors that increase your risk for melanoma, including personal or family history of melanoma, 50 or more common moles, atypical or large moles, red or light hair because they are less pigmented, so they're less protected from UV rays. Solar lentigines or sunspots, these are lesions that occur due to sun damage. Freckles, heavy sun exposure, sun lamps or tanning booths, light eye or skin color, severe blistering sunburns in childhood, immunosuppression, whether from HIV or chemotherapy, and lastly, a personal history of non-melanoma skin cancer. So by the way, why is immunosuppression there? It's because the immune system plays a role in removing cancer cells. So how could we prevent skin cancer? What are some of the measures that we could provide our patients in order for them to prevent having this condition? We have three here. Number one, avoid UV radiation. Limit time in the sun, especially during the midday. Also, wear sun protective clothing such as a wide brimmed hat as well as long sleeves. Next, avoid tanning beds. The UV radiation emitted by tanning beds are proven to be carcinogenic. So usage before the age of 35 increases melanoma risk by up to 75%. So it's good in a way that the beauty standards here in the Philippines do not include a tan skin, because tan skin, using the usage of tanning beds in order to achieve a tan skin actually increases your risk of melanoma. And lastly, the use of regular sunscreen has been proven to reduce the risk of melanoma. What type of sunscreen should we use? At least SPF 30. But most of the time we're going to see SPF 50. SPF 100 is okay as well, but it's a bit of an overkill. By the way, which UV radiations ano ba yung mga types of UV radiation? So you have UVA, UVB, and UVC. Fortunately, most of UVC is filtered out by the ozone layer. So this is listed in terms of increasing energy. Okay? So UVA is the one that causes skin cancer, while UVB is the one that is causing tanning. Okay. So actually, the USPSTF does not really recommend routine screening for general practitioners to screen for melanoma. Instead, what they suggest is that clinicians should be on the lookout for worrisome nevi. So, nevus in Tagalog is nunal. No? Okay. So, what are how do we identify worrisome nevi, or those that we suspect to be melanoma? So, we identify worrisome lesions by this mnemonic: A, B, C, D, and E. A for asymmetry. So, for example, this one looks benign because it's symmetrical. It's just circular. While in contrast, one side of the mole is lighter here compared to here. So it's asymmetrical. Next would be border irregularity. A benign nevus would have well-demarcated borders. In contrast, melanoma would be more stellate in appearance. So it could be notched or blurred, is because it invades surrounding tissue. It creeps into the surrounding tissues here. So it's more star-like in appearance. Next would be color variations. A benign one would have just one color, because it's just the proliferation of one type of a benign cell. However, in a melanoma, there may be more than two colors, especially blue, black, white, or red. If there's redness there, it means that there's already an inflammatory reaction to the abnormal cell. That's your body reacting to the cancer cells, most probably. Then if there is a white color, that's because of the loss of pigment due to regression. In other words, your melanocytes, your melanin-producing cells, have reverted back to their primitive or primordial phenotype, which is similar to what a cancer does. And lastly, we have diameter. So, normally, a nevus would be limited in its growth. In contrast, a melanoma would be uncontrolled in its growth. So, if its diameter is more than 6 millimeters, approximately the size of a pencil eraser, that would increase our suspicion for melanoma. And so, lastly, A, B, C, D, and E, we have evolving. In other words, you should ask whether the appearance has changed recently. Okay? So, among these, the most sensitive criterion that you have to identify is E for evolving. So, you should ask whether there has been a change recently. So you could ask the patient for older photos or ask them to describe it. So if any two or more of these criteria are present, then a biopsy should be considered. This is going to be done by either dermatologist or a dermatopathologist. So, just for completion, what's the EFG rule? So the EFG specifically helps detect further aggressive nodular melanomas, which is a subtype of melanomas. So EFG stands for elevated, firm to palpation, and growing progressively over several weeks. So if you have any of these features, it's going to be more likely to be aggressive. how do we perform the physical examination of the skin? Um, so first, there are some preparatory steps. You need to ensure that lighting is adequate. It's better if the lighting is natural. However, of course, you don't have control over our environment completely. So sometimes a strong ambient light is good enough. It's also useful to have a small ruler to measure if there are any lesions as well as a magnifying glass. You should ask the patient to change into a gown opening at the back in order to fully examine the body. And lastly, cleanse hands thoroughly before beginning. So the full body exam is crucial, especially for older patients. Who are these people? For example, men over 50, because it's important for us to check the areas that they could not check easily, including the back and the posterior legs. It's an opportunity for the early detection of skin cancers. So how do we describe skin findings? They're actually standardized terminology that we should keep in mind when writing in the medical chart. Accurate descriptions are essential. So you should include the following elements for each lesion that you find. So you could write the number. So of course you could write the actual number like 1, 2, 3. But if it's 1, you could say solitary. And if it's too many to count, you could write innumerable. Or you could just write multiple. You could also give an estimate of around maybe 10 to 20, something like that. So the size ideally should be given in millimeters or centimeter. For color, you could be specific. You should be specific. So you could say that it's erythematous if it's reddish, violaceous if it's slightly darker blue, brown or tan. You should also note if it blanches, whether the color disappears upon pressing, for example. For example, some vascular lesions, when you press them, they are going to blanch. Next is shape. You should describe if it's circular, oval, annular, meaning there's an outer layer here around the circumference, nummular or coin-like. Next is texture, whether it's smooth, fleshy, verrucous, meaning from the Latin word for verruca or wart, warty, is it scaly. Next, you should note the primary lesion. So there are specialized terms in dermatology that we're going to learn about in the next slide. So if it's flat, it's either a macule or a patch. A macule if it's smaller. If it's raised, it could be either a papule or a plaque. A papule if it's smaller. If it's fluid-filled, it's either a vesicle or a bulla. A vesicle if it's smaller. Okay? For the location, it should be as specific as possible, so you should know your anatomic landmarks. And lastly, you could give the configuration, whether it's grouped, whether it's linear. For example, some bed bug bites. No? There's like a pattern, a morning, afternoon, and dinner so-called pattern, which represents the movement of the parasite across your body. Another pattern another pattern is annular, and lastly, it could be dermatomal. For example, in shingles, it follows your dermatomes, the distribution, because the virus resides at your nerves. So here are the primary skin lesions that you should know about. So a lesion could be either flat, raised, or fluid-filled. So, and these terms would also differ depending on their size. So for example, if it's a small flat lesion less than 1 cm, it's called a macule. If it's more than 1 cm, it's a patch. For raised lesions, if it's smaller, it's called a papule. If it's larger, it's called a plaque. Okay? Fluid-filled lesions, on the other hand, could be either a vesicle if it's small or a bulla if it's more than 1 cm. There are some other related terms such as pustules. From the name itself, we could glean that it's actually pus-filled. A nodule is a deeper version of a papule. So if you move it around, it's going to feel that it's deeper in the layers of your tissue. Cysts are well encapsulated fluid-filled lesions. Wheals are like pantal in Tagalog. It comes from allergic reactions. So it's also synonymous with hives. Burrows are linear lesions seen in patients with scabies or galis in Tagalog. Galis aso. So what's the step-by-step when examining a patient for their skin, hair, and nails? So the patient should be seated. So it's depending on what's most convenient. Of course, if the patient is bedridden, they should examine them as is. So the bottom line is, there should just be a systematic approach so you make sure that nothing is missed. Also, you only remove the part of the gown that is covering the portion that is under examination. So you don't ask the patient to strip completely naked. Okay? So you start from head to toe similar to the other examinations of the physical examinations. So starting with the hair and scalp. So you should be able to part the hair properly in order to adequately visualize the scalp. Next, head and neck. Be sure also to inspect behind the ears. From that, you proceed to the back, the shoulders, and the upper extremities, the arms and hands. Should also don't forget to inspect the fingernails. That's followed by the chest and abdomen, then to the lower extremities, thighs, lower legs, feet, and toes. Be sure to inspect under the feet, the soles, and also between the toes. In order to inspect the buttocks, if you need to do that, you should ask the patient to stand. So lastly, the breast and genitalia may be saved for last because it's the most uncomfortable part. And especially if you're male, you could ask for a chaperone when you're examining a female patient. So let's focus on some special techniques. So there are special ways to test for hair loss. Take note that there's a difference between the hair pull test and the tug test. In the hair pull test, you're assessing shedding from the roots. So you gently pull 50 to 60 hairs to check for telogen effluvium. In contrast, in the tug test, you hold the middle of the hair and then you pull. You're assessing there the strength of the hair shaft, specifically whether it's fragile or prone to breakage. How about for bed-bound patients? You need to assess them for pressure ulcers. Pressure ulcers, also known as bed sores. Pressure ulcers come from sustained compression and shear forces. So when bed turning is not properly done, that could happen. So you should inspect the skin over the bony prominences. Where are the bony prominences of the body? In the sacrum, the buttocks, the greater trochanters, the knees, and the heels. So how do you stage the pressure ulcers of the patient? There are 4 stages, similar to most cancers, but it's not a cancer, of course. So stage 1 is just a reddened area that fails to blanch with pressure. So you should press on it. If it doesn't blanch, meaning it doesn't turn white, then it's already a stage 1 pressure ulcer. Stage 2 is a partial thickness loss, meaning the area that you could see could be reddish, which is already the dermis. Okay? Stage 3 means that there is full thickness loss. In other words, you could see the whitish subcutaneous tissue right here. But it should not go through the underlying muscle. Because if it goes through the underlying muscle, it's already stage 4. In stage 4, there could also be destruction of muscle, bone, tendons, and joints. So the bones of the patient could already be exposed. But here you're seeing pus actually. Could patients do self-examination for melanoma, especially elderly patients and the fair-skinned patients? They could do that. And how are we going to instruct them? So the patient is going to need a full-length mirror, a handheld mirror, and a well-lit room. Take note, 2 mirrors because they should be able to see hard-to-access areas like their back and the back of their neck. Those are frequently missed. So examine the body front to back, then right to side. So we're also going to tell them to look for it systematically. And of course with arms raised, otherwise it could cover some areas. Bend the elbows and look carefully at the forearms, underarms, and palms. Look at the back of the legs and feet, also the spaces between the toes as well as the soles. They could use the hand mirror to look at their back and their scalp. So of course they should also part their hair to look closer. And lastly, check the back and buttocks using the hand mirror. Let's read some sample documentations. So for example, if the findings are all normal, the skin is warm and dry, the nails are without clubbing or cyanosis, there are approximately 20 brown round macules located on the upper back, chest and arms, all symmetric in pigmentation. In other words, you're suggesting that you checked for the ABCDEs of melanoma. None are suspicious. There are no rash, petechiae, or ecchymosis. How about for suspicious findings? They are scattered, stuck on verrucous plaques on the back and the abdomen. So those could be warts, right? Caused by the human papilloma virus. Also, you could say here, over 30 small brown macules with symmetric pigmentation on back, chest, and arms. That's actually normal. But there was a single 1.2 by 1.6 centimeters, asymmetric dark brown and black plaque with erythematous uneven border on the left upper arm. So that's suspicious for a melanoma. Send for a biopsy via your dermatologist or dermatopathologist. Okay? How about for those whose conditions are not primarily skin, those with systemic findings? So for example, those patients who are bedridden for a long time at the medicine ward. What are some of the things you could find? So you could say that there is marked facial pallor and circumoral cyanosis. Palms are cold and moist. There is cyanosis in nail beds of fingers and toes. There are numerous palpable purpura on the lower legs bilaterally. And that's it for our meeting today. If you have any questions, don't hesitate to message me. I'm just one message away. Thank you, everyone.